Hello, everyone. My name is Mike Polson. I'm a general surgery resident at Boston University and Boston Medical Center, and I'll be discussing the role of structural racism and racial segregation in health outcomes, particularly as they relate to lung cancer. However, the lessons learned here apply to countless health outcomes in which racial disparities exist. Race, as we know, is a social and a political construct. It is in no way based in biology, but it's been used as a means to discriminate and to impose ideas of inferiority among certain groups. In the US, this is most apparent with Black Americans. But these notions are obviously false. When looking at racial disparities, we need to understand that these forces are driven by history, not inherent inferiority, genetics, or other false ideologies. Education focuses very little on the actual history of the United States and its repercussions today. The United States became the world power that it is because of the practice of slavery and the profit that was achieved on the backs of unpaid labor. Cotton was the primary staple of the South and drove much of the manufacturing of the North, which ultimately drove the entire economy. After the abolition of slavery, Black people were left to fend for themselves. Instead of receiving 40 acres and a mule, which was promised by the US government, they received nothing. And in fact, slaveholders were reimbursed for the loss of their slaves and the reduction in profits that came with losing their unpaid labor. But the slaves that brought them their wealth got nothing. Radical Reconstruction after the abolition of slavery saw short-term successes for the lives of Black Americans in the South as protections were enacted and enforced by Republicans at the time. However, as protections dwindled at the end of the 19th century, Black Americans were increasingly victims of white violence and lynchings in the South for which there were no protections from the police or government. A vivid example comes from Tulsa, Oklahoma, where white supremacists slaughtered hundreds of Black people in what was then referred to as Black Wall Street, in direct reaction to Black success. With any success garnered by Black Americans, white supremacists used violence to strip it away. Into the early 20th century, there was a large migration north as Black Americans fled violence and the sharecropping system that was binding them into a new slavery. Even in northern cities, Black people faced discrimination with limited job prospects and were often partitioned into certain parts of cities. Before 1910, greater than 90% of Black Americans lived in the South, and less than 10% of those lived in urban areas. By 1970, about 50% of Black Americans still resided in the South, but over 80% nationwide lived in urban areas. This was one of the largest internal migrations in our nation's history and really served to lock Black Americans into urban areas. In the 1930s, the Homeowners Loan Corporation, or HOLC, was a federally funded program that was created to rescue the housing market in the wake of the recession. They backed home loans, which were essentially limited only to white Americans. And around this time, housing developments in suburbs were also created, but again, were only limited to white Americans. Residential security maps of urban areas were created to assess the inherent risk of investment. Neighborhoods that were deemed hazardous or redlined did not qualify for federally backed loans. And these neighborhoods largely contained Black and other minority groups. Fraudulent housing practices and undue fear drove white Americans from their homes in these urban areas, which spurred a stark decrease in the home prices for the Black Americans that were left behind. And this is colloquially known as white flight. These practices, along with the GI Bill, really served to devalue Black communities and lock them into urban centers. Today, about 75% of those hazardous neighborhoods are low to middle income, and 65% are still primarily minority neighborhoods. So I'm going to be talking a lot about these redlining maps because this is really the most vivid example of the structure in structural racism. In talking about these redlining maps, I'll often use the HOLC grading system, A, B, C, and D, or green, blue, yellow, and red. So green areas were considered the best by HOLC standards, and you can see them here on the maps. And these communities would largely be composed of only white people. B is blue, and these were considered still desirable. C is yellow, and these were definitely declining. And then red was considered hazardous or the worst designation. And these neighborhoods would be made up largely of Black people. And if you compare the redlining maps to current demographic maps, you see a shocking overlap. So you can see the original redlining maps on the right and the demographic maps from 2010 on the left. And in the demographic maps on the left, you can see that green represents Black Americans and blue represents white Americans from the 2010 census. There's a clear link of these demographics to the redlined areas even to this day. So you see this here in Detroit. You see it in Chicago. And finally, you see it in And here's an economic study using census data over the last century to show the enduring impact of redlining. And you can see that the share of African Americans have remained the highest in these redlined areas. Home values and home ownership have remained the lowest over time. And while these maps may have been made in the 1930s, the repercussions are still apparent today in what we know as the social determinants. And in much of this talk, I'll be focusing on how the social determinants are really a function of structural racism. I'll use Boston as an example of the persistence of redlining today. And all of the following data comes from the 5-year estimates of the 2017 American Community Survey. And I'll be showing maps that illustrate clustering of the different studied socioeconomic and demographic data. And so this is a map depicting the redlining maps of Boston, which were made in the 1930s. The red and yellow areas again represent the areas that had a large minority share of the population, and thus those areas that did not qualify for federally backed home loans. And the following maps will show these same areas and the different socioeconomic impacts that redlining has made today. So keep in mind these red and yellow areas as we go through. So first here, you can see Black share of the population. And you can see from there's a clustering of Black residents from the 2017 American Community Survey within these red and yellow lined areas of Roxbury, Dorchester, and Mattapan in Boston. And the red represents large numbers of Black Americans, while blue represents low numbers. And you see similar clustering of poverty in these same historically redlined areas, where red represents higher percentages of people living below the poverty line, and blue represents low percentage. You see this with greater than 30% of income going towards housing, which is a measure of housing affordability. And again, you can see that a larger proportion of people within these historically redlined areas are paying towards housing. See this with public insurance in these same areas. And you see this with unemployment as well, again with red representing higher levels of unemployment. And finally, you see this with education. So here we see higher levels of people with less than a high school degree in these red areas, which again are historically redlined areas in Boston. And taken together, lack of home equity and limited job prospects have real and lasting impacts. Today, the median net worth of a white Bostonian is about $247,000, while the median net worth of a Black Bostonian is about $8. And homeownership has a significant impact on intergenerational wealth. And there are well-documented racial disparities in lung cancer screening and outcomes. Many of the previously discussed socioeconomic and demographic variables have also been shown to impact lung cancer outcomes. Patient income and employment status are important. Education level has also been shown to be important. And finally, patient level factors like smoking and alcohol use are obviously underlying factors that are important in outcomes, but these too have large racial disparities in prevalence. But all of these socioeconomic and patient level factors can be linked to the neighborhood in which you live. And the neighborhood in which you live has been planned, and the racial segregation has been perpetuated to this day. Primarily Black neighborhoods have historically been precluded from home loans, leading to large wealth gaps, poorer education, and other factors that lead to substance use, such as tobacco and alcohol. The social determinants of health are themselves inherently tied to the structural racism that came from the redlining of the 1930s. And so we've looked at the impact of residential segregation on different types of cancer, and particularly in lung cancer, which has shown striking findings. Here we look at the proportion of Black and white patients presenting at advanced stage in different areas with different levels of segregation. And here on the x-axis, low numbers represent low levels of segregation, and high numbers represent high levels of segregation. And we see that disparities in advanced stage between Black and white patients disappear in areas with low levels of segregation. And so there are similar findings with surgical resection. And we see that at low levels of segregation, again, low numbers on the x-axis, there are no racial disparities in surgical resection between Black and white patients. And finally, we compare Black and white patients in high and low levels of segregation in terms of hazards of cancer-specific death. We see that Black patients in low levels of segregation, here represented by low IOD, have more similar hazards of death compared to white patients than Black patients in the high levels of segregation, which is represented by high IOD here. So overall, low levels of segregation are associated with no or lessened disparities between Black and white patients, lending further credence to the idea that one's neighborhood and not their genetics contribute to racial disparities. And where you live has really been predetermined by a racist history. So racial disparities can be fixed, but solutions will not come from within the healthcare system alone. Repetitive action for historical racist practices and their perpetuation today can serve to reinvest in devalued communities to alleviate the social determinants of health that lead to the racial disparities that we see today. Thank you very much for listening. I'm happy to answer questions by email or by Twitter.